Hi guys, welcome back to the channel. We are today discussing ANDROMEDA trial effect of resuscitation strategy targeting peripheral perfusion status versus serum lactate level on a 28-day mortality among with a septic shock.
Disclaimer: the content of information on this video is for education purpose only and is not intended to be recommendation of any kind of sin whatever. Under any circumstances, we author accept no label for any indirect, incidental, consequential, exemplary damages arising. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: in adult patients with early septic shock, does the peripheral perfusion targeted resuscitation compared to the lactate level targeting resuscitation improve all-cause mortality at 28 days? Background: the Surviving Sepsis campaign recommended the targeting the normalization of lactate when a resuscitation patient with septic shock. However, the problem exists with lactate as a target, including the hyperlactemia, may cause by factor other than perfusion. Example: liver or kidney failure, metabolic changes or drugs. Lactate normalization may be delayed to after shock resolution. Lactate measurement may not be mostly available in developing countries. Capillary refill time (CRT) is a marker of peripheral perfusion with the sympathetic nervous system activation has been associated with the organ failure and mortality. It may alternate to target to the lactate guided resuscitation and has a floral protection advantage over the lactate, including the rapidly response to the resuscitation. It is easy to use a resource independent method of a peripheral perfusion. Design for the study: this is multi-center randomized controlled preparatory trial. Random allocation with a central allocation of consignment. Randomization sequenced by permitted blocks of 8 with 1:1 allocation via computer program. Clinician non-blinded. Power calculation: 420 patients were included to give 90% power to detect absolute risk reduction of mortality from 45 to 30. Relative risk reduction is 33%. Primary outcome calculated using the Cox proportional hazard after the adjusting about 5 pre-specified cohorts. Intention to treat analysis: setting 28 hospitals in South and Central American countries: Argentina, Chile, Colombia, Ecuador, or Uruguay. Population for this study: inclusion criteria: age more than 18-year-old patient with early less than 4 hours septic shock admitted to the ICU. Septic shock was defined according to the Section 3 definition: suspected or confirmed infection, lactate more than 2, vasopressor to maintain MAP more than 65 despite 20 ml per kg over the 60 minutes. Or exclusion criteria: bleeding, severe ARDS, dialysis patients, and those who do not resuscitate status. Study flow: 1327 assessed for eligibility, 903 patients, including 286 as of more than 4 hours and 208 anticipated surgery or dialysis, 108 do not resuscitate, and 55 eligible but excluded due to the logical reason. 424 randomized, 212 CRT targeted and 212 lactate targeted. Baseline characteristics were similar between the groups: mean age 63, Apache score 22, mean SOPA score 9.6. Emergency department source of admission in a 71%, intra-abdominal most common source of infection 35, followed by pneumonia 30 and UTI 20%. Intervention: peripheral perfusion targeted resuscitation. Capillary refill time was measured every 30 minutes and then hourly after normalization for 8 hours. CRT was measured by applying a glass microscope slide to the right index finger at the distal phalanx until the finger was blank, then maintained for 10 seconds. The time to return normal skin color was measured using the chronometer. Abnormal CRT was defined as more than 3 seconds, and goal of resuscitation was to normalize CRT less than 3 seconds. Control group: Lactate level targeted resuscitation. Lactate was measured every 2 hours for 8 hours. Goal of resuscitation was to normalize or decrease the lactate level by 20 every 2 hours. Management common to the both groups. Patients who did not meet the above goals, CRT less than 3 seconds or lactate less than 20, lactate fall in less than 20% every 2 hours, were then managed with the following protocol over the 8 hours period of the study. Step 1. Fluid responsiveness. Patients were first assessed for fluid responsiveness, most commonly pulse pressure variation or change in velocity time interval post passive leg rise test. 500 ml crystallite bolus was given every 30 minutes until the goal was achieved. Then the stock is no longer responsive. Vasopressor test. Chronic hypertensive patient had a vasopressor test. Targeted map increased to the 80 to 85. If CRT or lactate normalized, map was left at 80 to 85. If no change, then map was reduced back to the target 65. Step 3. Inodilator test. If patient still did not meet the target, then inodilator test was done where the dopamine or millineuron were introduced. All other aspects were according to the surveying sepsis guidelines. Primary outcome. Day 28 mortality higher in lactate group, 90 to 43%, 43.4% in the lactate group and 74 patients in the peripheral perfusion group. Hazard ratio 7.75. And impact of the protocol. Compared to the lactate group, the CRT group had 408 ml less fluid in first 8 hours, less adrenaline use 9.9 versus 16.5, lower lactate at 48 hours and 72 hours, lower CRT levels at 4, 8 and 24 hours. QB and central venous saturation did not differ. Secondary outcome. SOPA score lower at the first 72 hours in CRT group. No other significant difference between the group in the other secondary outcomes. Mechanical ventilation 3 days at a 28, RRT 3 days at a 28 days, vasopressor 3 days at a 28, ICU length of stay, hospital length of stay. Predefined subgroup analysis, baseline SOPA score less than 10 associated with a 28-day mortality, and whereas the SOPA score more than 10 was not significantly different. Strength of the study. Multinational randomized control trial with allocation of consignment, registered with the clinical trials, pre-published statistical plan. Time from the eligibility to randomization is 1.4 hours, suggesting an early intervention. Rapid recruitment. CRT assessing was standardized using chronometer, staff training, auditing, and periodic reinforcement, and good adherence to the protocol with no loss of follow-up. Weaknesses. Underpowered to answer the study question. The sample size was calculated based on AR of a mortality of 15%, which is unrealistic for the most resuscitation-based sepsis studies. Therefore, although the study result in 8.5 mortality difference, this did not meet the pre-specified significance level. Thus, there was a high chance of type false negative error. Formal Bayesian analysis will be potentially allowed to more nuanced interpretation of the trial. No blinding of the clinician may have lead to the additional changes in a management, resulting in bias for the intervention. CRT group also require additional staff education, while the lactate group did not, again potentially favoring the CRT intervention. While both arms had a CRT assessment every 30 minutes, protocol adjustments were only made every 2 hours for the lactate group. The reduced frequency of protocol adjustment may have been biased and result against the lactate group. Complex intervention making the causal relationship of outcome difficult to explain. The two arms of the study trigger a complex protocol of which parts lack of strong evidence, which may be biased the result for the against improvement outcome. Furthermore, the parts of protocol are advanced, fluid responsive, vasopressor, inodilator assessment may not be generalized to other hospitals. The combination of lactate-based study, the CID strategy was not tested. Although the CID technique was standardized, there has been relatively little literature on this technique. No evaluation of inter-rater variability was conducted in the trial. The day 28 was as a primary outcome in a sepsis trial has been shown to still unstable, and most major trials now using the 90-day model. Author conclusion: among the patients with a septic shock and resuscitation strategy, targeting the normalization of capillary refill time compared with the strategy targeting serum lactate level did not reduce all cause of 20-day mortality. The bottom line: the study suggests that exclusive use of CRT is a possible alternative to lactate as a resuscitation target in sepsis, especially in resource-poor settings where lactate measurement is not routinely available. My practice is to use a combination of lactate clearance and capillary return, which this study did not address, and therefore it will not change my practice. Further, adequately powered studies with evaluation of CRT technique in other settings and countries will be needed to make CRT my exclusive target for septic resuscitation.